Well, that's the intention of these guidelines, is to integrate this into a practical approach. And in a busy neurology clinic, it's not possible to spend 40 minutes on bladder and sexual dysfunction. But during the course of the interview with the patient and sort of inquiring about symptoms and asking about the bladder, asking about sexual problems, actually is giving permission to the patient to actually open up on this. And many times what one would find is that patients will then will provide more information. So with a history and then having a bladder scan that measures a post-ward residual volume would be something that could be practically implementable in most neurology clinics. The post-ward residual could be measured if there's a handheld scanner. Perhaps one of the members of a neurology team would be trained in that, or having a friendly radiology department that allows patients to go down to have the post-ward residual measured. Having in-out catheterization is a third option, but it does sort of have a risk for developing urinary tract infections. But that plus measuring testing for a urinary tract infection are bedside assessments that can be performed in most neurological outpatient settings or inpatient settings. Now, in terms of treatments, we provide in the guidelines a sort of an approach on the first line and the second line treatments. And the treatments that are being proposed that I mentioned to you earlier are treatments that a neurologist are able to prescribe. And so we don't go into options such as surgery or botulinum toxin into the bladder, because that would require your urology colleagues. But what we do provide is sort of the cutoffs or the criteria, the red flags when you should refer. And one of them would be that if the first line treatments are not effective, then the patients are then referred on. For sexual dysfunctions, it's similar as well. The history, the examination, all can be done in a neurology setting, and the medications and knowing about the side effects means a safe prescription for the patients. So I would say the number one gap is, as neurologists, and I included, do not ask about bladder and sexual dysfunction. I mean, this is in our training, it's not there, and therefore in practice, we wouldn't necessarily be confident in this unless we've had some exposure to it. So this provides a framework for actually neurologists now delving into this area, and provides a space where neurologists can then follow a structured approach, and so by that we hope to actually fill the gap. What we're not sure is the practicalities of implementation, and we hope that's a piece of work for the future to see what would be the barriers in actually introducing this as a practice. But we have a task force that's made up of neurologists predominantly, but also urologists, and the recommendations that are coming out are actually produced by this task, or by the steering committee and this task force, where careful consideration has been made in regards to whether it is actually practical to have this. So we feel that this is a piece of work that will fill the gap in regards to assessing and managing urogenital symptoms in neurological patients.